Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today introducing the March podcasts. And we have a very nice selection of podcasts for you this month. First, I'm doing an interview with someone who's actually a trainee, still a resident, in Germany, Dr. Sebastian Bickelhaupt, and we're talking about a fast way of looking at images from X-ray breast cancer screening using diffusion-weighted MR with maximum intensity projections. Then Dr. Kressel had a very nice interview talking to three people, Drs. Brook, Pedrosa, and Megabo, about delayed growth in incidental pancreatic cysts and asking the question of if the current ACR recommendations for follow-up are appropriate. And then finally, we have a more basic research study in a small animal model. And Dr. DeRoos is speaking to Dr. Sebastian Kuzerki from Zurich, Switzerland, about using hyperpolarized metabolic MR imaging of acute myocardial changes in recovery on ischemia reperfusion in a small animal model. So basically, we have three great research projects to discuss and three interesting podcasts. I hope you enjoy them. Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today talking with Dr. Sebastian Bickelhaupt, who's from the German Cancer Research Center, and he's actually a resident in the Department of Radiology in Heidelberg, Germany. He and his group have done an interesting research project that we're publishing in the March issue of Radiology. It's entitled Fast and Non-Invasive Characterization of Suspicious Lesions Detected on X-ray Cancer Screening, Capability of Diffusion-Weighted MRI with Maximum Intensity Projections. So welcome, Dr. Bickelhaupt.
Thank you very much for this kind introduction.
So can you tell me a little bit about what you did and what you found?
Yes, so what we did in the study is that we looked at women who had a suspicious lesion in terms of BI-RADS 4 or 5 in their primary screening X-ray mammogram, and we invited them to participate in this study where we investigated if we can increase the positive predictive value prior to the biopsy that's being performed with the use of diffusion-weighted imaging without the use of contrast agents.
And what did you find?
So what we did find is that using an abbreviated diffusion-weighted imaging protocol can help us to detect a very high rate of false positive lesions as described on their primary X-ray screening mammogram with this high positive predictive value that's increased from about 50% without the diffusion-weighted imaging protocol up to about 90%. By using this protocol can omit a substantial rate of unnecessary biopsies.
So you describe in your methods that this is actually an interim analysis of 50 women who had, I guess, BI-RADS 4 and 5 lesions on X-ray mammograms, and
Exactly.
So had an indication for biopsy. So these are very high-risk women. And that your complete study is going to have two groups of 100 people. And I'm just wondering, what made you decide to do an interim analysis?
So when we did the study design, as you said, we wanted to have a far larger number of study subjects. And when we looked at the initial results, we decided that they are so significant that we should report it just in order not to delay to get those things published to the scientific community.
And you looked at two different abbreviated reading protocols. I'm wondering if you can describe those two different protocols and why you decided to use those.
Yes. When we looked at the MR imaging, breast imaging, the standard protocols, they all use contrast agents. We have a recent publication that used an abbreviated contrast-enhanced MR protocol with a very good success in primary screening, not for the clarification of known lesions. And so we decided that we want to build up a protocol that's really short so that it can be used in a screening setting. We wanted it to be contrast agent free, and then we decided to use only T2-weighted sequences and diffusion-weighted sequences and a abbreviated contrast-enhanced protocol that's similar to previously published protocols.
So you talk about screening, and obviously with a 50-50 mix of cancers and benign lesions, this is not a screening protocol. And yet your results with your negative predictive value being so good are very encouraging. But 92% is what you found. And is that really going to be sufficient when you have a different kind of population in a screening setting?
So yes, as you said correctly, our study does not resemble a primary screening group, but it's just a group that was that had the indication to go for a biopsy. When we look at the negative predictive value, which was above 90%, of course we have to say that we missed especially DCIS lesions, which only did show up by microcalcifications in the X-ray mammogram, and that's a known problem for MR imaging. And we know that the sensitivity of MR imaging is not exactly 100%, but below, especially for DCIS lesions. So we kind of expected it. However, we have to look at the final results in the whole study group to see what implications can be drawn from our findings.
And when you look at your study population with the 50 patients, you end up with only 2 cases of pure DCIS, which seems a little bit low for this kind of population. Do you think there was some kind of bias in the recruitment of patients that this ended up to be so low?
So I don't think that there was a bias in the selection of the patients, because it was just the first 50 patients that were included in the study. And when we look in the ongoing study, or we have just stopped the recruitment for the entire study, we see that the percentage raises. So of course we can say that there is some sort of bias in this study population that we published in Radiology. However, it was not caused by the selection of the patient population, but rather just by, let's say, pure luck that we had there. When we included more patients, the number raised.
So getting back to your results and thinking about using this in a high-risk population like what you have here, could you imagine being able to use this kind of unenhanced, background suppressed, diffusion-weighted MIP images as part of a routine full breast MR that would then allow you to omit some of the longer standard sequences or even omit contrast?
So I do not think that we are at a point to be able to discuss about omitting contrast in breast imaging. Definitely not. It was a dedicated question that we had. We had known lesions in our patient population. We knew where the lesions were. And we used diffusion-weighted imaging in order to increase the specificity to know what the lesions really are on a histopathologic level. I don't think that diffusion-weighted imaging can be currently used as a primary screening tool, neither in order to omit contrast-enhanced sequences in clinical routine. However, I feel and I think when we look at the recent publications that contrast-enhanced MR cannot be omitted, but diffusion-weighted imaging should be included in clinical routine in order to increase the specificity.
Great. And then one of the reviewers, when your manuscript went through our initial set of review, brought up the issue of mucinous tumors, which can have high ADC. And the reviewer mentioned that these weren't well represented in your study. And I'm just wondering how you can comment on lack of this type of tumor as a theoretical limitation of your approach.
Yeah. It basically is something like what we talked before about the DCIS lesion. There were just consecutive patients that we recruited from our screening center. And of course, there is this issue with mucinous carcinoma that can have a very high ADC value. However, we did not only focus on looking on the ADC map or the ADC value quantification, but we looked on both the diffusion-weighted image, the ADC map, and the T2 weighted images, which then gives us a very good overall impression, not meaning that this is a technique that will identify 100% of all malignant lesions under all circumstances. I guess that would be very much an overinterpretation of the data.
Okay. And you mentioned that, well, it's now a year since you ended this interim analysis and you just stopped recruiting patients. I'm wondering, how is the data analysis going? Was there anything unexpected with your complete study results?
So we just finished, or we finished the recruitment, and currently our biostatistical experts are working on the data. There's not that much unexpected that we see in the data as we've analyzed it so far, and we are really happy and kind of curious to be able to publish the whole data set, because we think there are important data for breast cancer detection, screening, and the clarification of unknown lesion, which is a tremendous burden for the women. And yeah, we are happy to show the results very soon.
And what additional questions will you be answering with this full data set?
A very important point is just to increase the pure size of the study group. And a second important question is that with the entire study, we did not only include one vendor with one dedicated diffusion-weighted imaging sequence, but there are different vendors. We developed a dedicated quality assurance protocol for diffusion-weighted images. Our medical physicists, they developed dedicated quality assurance phantoms for diffusion-weighted imaging of the breasts. And all this will be included in the entire data set. And yeah, one very important question that's always raised is how can diffusion-weighted imaging be implemented into clinical routine, because everyone has his own small protocol, different p-values, different slice thickness, and we tried to find a standardized way to do that and to implement it prospectively into this study.
Well, that sounds very interesting. I'm going to look forward to seeing your more formalized final results. Well, thank you so much for your time talking with me today.
Thank you for your time. It was a pleasure.
Hi, this is Herb Kressel, editor of Radiology, and today I am joined by Drs. Olga Brook, who's assistant professor of radiology at Beth Israel Deaconess, and Dr. Ivan Pedroza, who is associate professor of radiology at the University of Texas Southwestern, and who formerly was at Beth Israel Deaconess. And rounding out our panel today is Dr. Alec Megabo, a professor of radiology at NYU and a member of the ACR Incidental Findings Committee. Dr. Megabo heads up the pancreatic cyst group. So welcome, Drs. Megabo, Brook, and Pedroza.
Hello. Hello, Dr. Kressel.
Yeah, today we'll be speaking about an article appearing in this month's journal entitled Delayed Growth in Incidental Pancreatic Cysts. Are the current ACR recommendations for follow-up appropriate? And I thought this a very timely article, and it both answered and asked a number of questions that have personally troubled me over the years. So why don't we begin? Dr. Pedroza, why did you actually undertake this study? What was kind of driving what turned into an awful lot of work?
Well, I think when the ACR committee came up with the paper with the guidelines, I thought it was a great contribution, and it helped us really manage many of these cysts. I thought there was, however, a little bit of a lack of data regarding the very small cysts, the ones that are smaller than 2 centimeters with no complex features. And anecdotally, I have seen in my career cysts that grew very slowly over time, and I wonder if a single 1-year follow-up was sufficient to really disregard lesion as being benign and not having any associated risks. So we contemplated doing a retrospective review of our data to see what was the reality in terms of growth kinetics for these cysts.
Now, Dr. Megavo, perhaps you can kind of enrich this and kind of bring us the context of sort of why the college decided to develop separate criteria. I'm aware that the Sendai criteria exist. There were the AGA developed separate criteria for gastroenterologists, and I believe the surgeons had developed criteria. So what was the reason for developing separate criteria, and then what specific criteria did you come up with?
Well, radiologists are in a tremendous disadvantage with these because we often detect these things as totally incidental findings. We have a vague understanding that they may or may not be neoplastic. And it's hard to know what to do when you see them. Now, I want to just specifically state that our original paper were recommendations, not guidelines. There's a slightly less rigor involved with recommendations, but nevertheless, we thought that we could encompass some way of helping a radiologist when he's confronted with a single case get some handle as to what to do with that particular cyst. That's why we did it. Now, the other guidelines that have been published were really being put together at the time the ACR did this. And remember, the paper was published in 2010, which means that the data and the case experience was collected really well before then. So that's where we were at the time.
I see. And Dr. Brook, what did you actually do in your study? Tell us about sort of the method and what you did.
So we specifically evaluated a subset of pancreatic cysts, namely small, meaning less than 2 centimeters in size, incidental and asymptomatic cysts. We included patients who had MR studies at least 6 months apart, preferably more, but at least 6 months apart, and we evaluated the size and change in size over the time. We had a pretty large group of patients because we included patients starting from 1999 to December 2011. And we did also evaluate it both for size changes and obviously for clinical follow-up of those patients.
Okay, well, as I looked at the paper, it seems that the definition of change that you used of interval growth was 2.5 millimeters, and the reason that it was chosen was that it was close to the size or the range of a single pixel using the parameters in your MR protocols. And so that's a very tricky kind of measurement, and you did a great job, the author group, in training everyone to be successful in using this, but it raises the question, is MR actually the best way to follow these lesions if it's fundamentally sort of the resolution is at the edge of the type of change you're trying to detect? Dr. Pedrosa, what do you think about that?
Well, definitely a problem for us to go below that resolution. Most clinical protocols will be at that level. So that's what we wanted. Since this was retrospective, we didn't have an option, but also we want to reflect what happens in clinical practice. One could argue that better resolution will provide better accurate measurement of growth. I don't think there's a question about that. And in that sense, CT or even ultrasound, if one has a good view of the pancreas, provides better resolution than MRI. MRI obviously has the advantage of no radiation for longitudinal scans when we do multiple of these tests.
Okay. Dr. Megabo, what do you think?
Well, I think growth is a very difficult parameter to measure. Obviously, it's critical. And we're struggling with this in a separate venue in Society of Abdominal Radiology, disease-focused panel on pancreatic cysts. And how do you actually define growth? And in which dimension do you measure? I mean, this is a very hot topic that is not totally figured out at this point. At NYU, we sort of made a decision that we would accept growth as a 20% change in the long axis diameter compared with baseline. Or if the cyst was smaller, if the cyst was under a centimeter, we'd want to see it double before we would call it growing, based on errors in electronic caliper placement. But this is a really hot topic. But nevertheless, I think for the point of the paper in question, their really meticulous assessment of this was quite important and very well done.
Very impressive, I thought, I must add. So, Dr. Brook, could you highlight some of the key results that you found?
So what we found in overall is median follow-up time of 2.2 years. Majority of the cysts were stable, 66%. However, 26% actually enlarged in size. And most importantly, 11% actually increased after documented 1 year of stability. And some of them actually increased after 2 years and 3 years of stability. So just the fact that the cyst is stable for a few years does not mean it will not grow later. The overall increase in size was not very dramatic, about 2 millimeters a year, but still this is something that is definitely increase in size over years.
I see. Now, I found that interesting that 7% of the cysts actually decreased in size. Any thoughts as to sort of why this is occurring? Is this a real physiologic change, or is this a problem of partial volume effects in finding these small cysts in some patients? Dr. Brook?
So some of them, we excluded all the patients that underwent some sort of intervention. It's hard to say what was it. I would not think that it was just a measurement error. I think it's some sort of physiological change, rare, but it's in this large group of patients we see it happens.
I see. Dr. Megabo, any thoughts as to sort of what's happening with these patients and the disappearing cysts?
Well, I mean, it's been pretty well reported that pancreatic cysts, particularly IPMNs, can actually decrease in size. People have suggested that the mucin within the cyst is actually expressed into the pancreatic duct, and the thing kind of shrivels. But these things are mysterious.
I see. Do they ever come back after they've shrunk, in your knowledge?
I would imagine that that empty casing could refill with mucin. I don't have case experience with that, but, you know, anything is possible.
Anything is possible. Yes. So, Dr. Brook, as you noted, 26% increased, and nearly half of those increased after not showing change in the first year. What was actually the range of intervals? How long after first identified was the range that you could see change after being quiescent?
So up to some of the cysts increased after 2 years instability. It's about 6% and 1.5% after 3 years of stability. So it's rare, but it's definitely may happen even 3 years down the line.
Thank you. As I looked at the data, it was hard for me to understand if there was any systematic way that the clinicians were following these. The range of follow-ups and the intervals seemed to sort of be all over the place. You do note that for the larger cysts, there was a longer period of follow-up. And Dr. Pedroza, in general, do you recall what were the guidelines that clinicians were using at your institution at the time, at Beth Israel Deaconess?
Right. So Dr. Megabo referred before to the existing guidelines, and back then, really the Sendai guidelines were the only ones that were available. So our center, BI, is a tertiary center for pancreatic disease. So those patients that were referred to the pancreas center, both for gastroenterology follow-up or surgical follow-up, did follow in general the Sendai guidelines. But many of these cysts, as Dr. Megalo referred to, are cysts encountered incidentally in an MRI done ordered by a PCP or some other specialist, or something completely unrelated. So those patients, my sense, and we didn't look at this systematically, my sense is these patients were not necessarily followed based on any guidelines, but more on the recommendations from the radiology report.
So one of the, it's in the title and it's also in the discussion, you suggest that the ACR, existing ACR guidelines be revisited, and I'm delighted that Dr. Megabo, who heads up the pancreatic cyst group of the ACR Committee on Incidental Findings, is joining us. And perhaps you could bring us up to date. Do you agree that these need to be revisited? And if so, where are we in the process?
Well, yes, 100% they need to be revisited and revised for several reasons. I mean, the explosion of knowledge about pancreatic cysts, both in terms of longitudinal history, growth rate, which was something that we didn't really anticipate previously, type of growth, and then all of the molecular risk stratification that you can get from EUS or aspiration of these cysts was really unknown to us at the time that we put those together. I would like to say that when we wrote that original paper, we stated that this was a stake in the ground that should hopefully stimulate research. This paper is exactly what we wanted to gain the knowledge based on this, on what we had suggested to help us revise this. And we fully anticipated that we would be revising it, and we are in the process of revising it now. The leader, the head of the ACR Incidental Findings Committee, Pari Pandharapandi, also an NYU graduate, is expecting the finished manuscript in July. And we have a committee of 5 radiologists, a gastroenterologist, and a surgeon who are going to be putting this one together because just of the expansion of knowledge and the need for a more multidisciplinary approach.
You want to give us any clues as to what changes we might expect?
You'll just have to watch.
Okay.
Well, I mean, I'm sorry.
Because Dr. Megabo is not forthcoming, that gives Dr. Pedroza-Brook free rein. Any suggestions you want to give to the somewhat recalcitrant Dr. Megabo?
Well, I'm not going to offer suggestions if the chair of the committee doesn't. But I think that the purpose of this was exactly what Dr. Megabo mentioned, is to provide data. I think the initial recommendations were great. I think we as a society have the responsibility to continue to do research in this area and provide data so those can be refined and provide something that is more evidence-based. And understanding that our study is a retrospective study with the limitations of any retrospective study, it's very hard to do prospective studies in this area, but I think it's something that we probably need to make an effort to create some sort of prospective data gathering and analysis.
So, Dr. Megabo, not to sort of beg the point, but can we anticipate that you'll be incorporating some factors that might risk stratify these individuals based on clinical information?
Oh yeah, no, 100%. We'll have to incorporate that. We have to incorporate what Yvonne and Olga have determined about delayed quote-unquote growth based on an earlier metric. We have to include molecular information that can be gleaned and really look at this with a sensitivity to the frequency of these cysts in the population, which the AGA estimated at 3 million out there, and the extremely low likelihood of cancer in these things, and the ultimate cost in the cost per life saved. So we're also looking, hopefully we'll be able to do some cost analysis on this, maybe not for this paper, but there's a lot of stuff that really needs to be rethought now in light of current knowledge.
Well, I think along those lines, and I think the paper sort of pointed this out, I think we have a very important subgroup here because pancreatic cancer is a serious problem. And so being able to find it early and being able to affect important outcome changes is important. On the other hand, it does seem ripe as a potential candidate for overutilization. So one of the thoughts that occurred to me is, should we think about other modalities, or, people develop these nomograms to try to risk stratify that subpopulation that is at highest risk. So what about other modalities, Dr. Pedrosa?
Well, certainly in the cost analysis, you have to incorporate the other modalities, not just MR, because there are better ways, not economically, but cheaper ways to evaluate pancreas. But of course, you have to include the sensitivity and specificity of the test when you do that kind of analysis. I think something that complicates the question even more is the whole notion that there's a field effect, right? That the patients that have a cyst have a risk for developing pancreatic cancer anywhere in the gland. Right. And that makes things even more complicated because, first of all, we don't know how sensitive we are to detect those cancers early. Second of all, we don't know if we detect those lesions early, we actually affect the outcome of the patient.
Right. Dr. Brook, any thoughts about this? What's happening at Beth Israel Deaconess these days in this regard?
I think one of the modalities that we should seriously try to evaluate for evaluation of pancreatic cyst is ultrasound. It's in certain subtypes of patients, smaller patients. This pancreas can be well evaluated by ultrasound, and especially as we establish, we may try to alternate MR with ultrasound to also catch on both sensitivity, have high yield from MR, but in the interim decrease the cost with interim ultrasounds.
Interesting. Dr. Megabo, you told me you're the oldest person in the room. Any last thoughts from our senior statesman? Where do we go from here?
Well, I think there are a couple of thoughts. I think first, at this point to learn about these, we're probably going to enter a phase of doing more imaging rather than less because there's too much confusion. We need larger patient populations on which to make less or more evidence-based decisions. That's the first thing. And so there's some collaborative efforts underway where we welcome participations from many different centers in order to fast track that. Second is the big question here, what is the significance of growth? Because in a lot of papers, many of these lesions grow, they're operated on, but they don't have cancer. Mm-hmm. So growth is a factor, but I think, and we'll have to incorporate this in the guidelines, that there's more information that has to be gleaned from that growing cyst before it's taken out or watched more frequently. I think it's at a tipping point in terms of more laser focus and more complete evaluation.
Great. Well, I want to thank you all for a very stimulating discussion on a very important topic, and thank you for your time and your insights.
Thank you.
Bye.
Bye.
Hello, my name is Albert de Roos. I'm the Deputy Editor of Radiology for Cardiac Papers. And today I'm joined by Sebastian Kozerke from the University of Zurich to discuss a very interesting paper which is already available online and it's entitled Hyperpolarized Metabolic MR Imaging of Acute Myocardial Changes and Recovery After Ischemia Reperfusion in a Small Animal Model. Welcome, Dr. Kozerke.
Very good morning. Thank you.
So it's a very interesting article, but maybe also somewhat difficult to understand all the basic principles for radiologists, and you are a physicist who is trained very much into the details of this technology. So, but I should like to invite you to start with a hopefully somewhat understandable and simple explanation of this principle of hyperpolarized metabolic MR imaging.
Yes, so while conventional MR relies on the abundance of protons in water, and that's also the reason why it works so well, you face an issue when you want to probe nuclei other than water. And when we look at metabolic substances, for example, we want to look at carbon. But carbon in itself has a very low polarization, hence it gives a very low signal. In order to address this limitation, hyperpolarization techniques have been developed. And what they essentially do is they take these molecules and freeze them to a very low temperature. And while doing this in a magnet, you can transfer magnetization or polarization from electrons down to the nuclei, hence increasing the magnetization of these substances. In order to make them accessible to in vivo experimentation, you have to dissolve these kind of molecules from very low temperature back to body temperature, and that happens in a dissolution process. And that's why the entire procedure is called dissolution, DNP, dynamic nuclear polarization. And that's the principle we are using here. What we have as a result is a highly magnetized substrate. Here we use endogenous substrates, meaning that they can be injected back into the organism without problem. And upon injection, we can follow the fate of these substrates in living cells, living organisms, and eventually in humans.
Okay, so that's the basic application of this technology. But to use this technology, we have also to develop some understanding of the basic biochemistry which you are using to probe these substances. And my understanding was that you were using pyruphate as a marker, and that's transformed into other substances, and that you can follow this transformation dynamically. Can you explain a little bit the basic biochemistry and why you have chosen pyruphate and which metabolic products are most interesting, especially when we are looking for the heart?
Yes. Well, excellent question. So there are essentially two substrates that are being used to produce ATP, adenosine triphosphate, so the primary energy currency of cells in general. And these are fatty acids and carbohydrates. When we look at pyruvate, so pyruvate is a breakdown product of glycolysis, meaning the oxidation of carbohydrates. It sits at a very central crossroad of metabolism in the cell, and that's why pyruvate is chosen. It is interesting because of its metabolic importance, but it's also interesting because it can be hyperpolarized very well. So that's why it's a primary molecule of interest in these kind of experiments. Once pyruvate enters the cell, it will be converted, depending on the oxygen state, into lactate, alanine, and bicarbonate. While bicarbonate reflects mitochondrial activity, meaning that we can probe mitochondrial activity of cells non-invasively and with rather high resolution both in space and time.
So that's a very intriguing aspect, that actually you probe the function of the mitochondria and their metabolism. And we will shortly discuss the model of heart disease you studied. But first, when there is ischemia or heart disease, how this will affect this metabolism? What will happen and which changes you might expect?
In ischemia, of course, we have a shortage of oxygen, and hence the metabolism will change. In response to a shortage of oxygen, lactate will increase, so meaning that we run anaerobic oxidation there, glycolysis, and bicarbonate in response will go down. And this is what we have been using as a marker of ischemia, transient ischemia in our study. But in general, it is very attractive to look at the state of oxygen and metabolic substrate utilization in the cell.
Okay, now we have some basic understanding of the principle and the biochemistry. And what was your purpose and how you used this technology and for which specific question?
The interesting question we have asked here, and others have asked as well, is what happens if there's a shortage of blood supply to the heart? Well, obviously there's a perfusion reserve, and on the other hand we also have a functional reserve, but in between we have a metabolic reserve as well. So meaning that if there's a shortage of oxygen, then metabolism changes. And the hypothesis was that this can be an early marker of ischemia in general, but also an early marker of detecting area at risk more reliably. So as we all know, T2-weighted MR imaging has limitations when identifying the area at risk. And here we really look at the consequence of a shortage of oxygen in, by looking at metabolic changes.
And your model was a rat model of coronary occlusion, temporary coronary occlusion.
Yes.
And what was the specific purpose of this model? To induce a transient ischemia and not a full infarction, is my understanding. Can you explain it a little bit?
Yeah, exactly. So the purpose of the model was to induce a transient ischemia, so very short occlusion time, and then immediately followed by reperfusion, so as to not produce scar tissue. So we wanted to see the transient change, and we of course all know that there's a functional change included, but this functional recovery happens rather soon once there's perfusion resumed. But it might be that the metabolic alteration continues for longer and hence can be used as a marker of transient ischemia that may not be picked up by a functional study while looking at cardiac motion in general.
Yeah. So these metabolic changes are considered to be the most early phenomenon. And in a transient stunt myocardium, perhaps, you can assess basically the viability and recovery of metabolic function. Potentially. So what were the actual results of your study and what was the main conclusion from it?
So the key design of our study was that we could study the animal longitudinally, so at different time points, so at baseline, right after ischemia, reperfusion, and then at several time points later on at 30, 60 minutes, followed by a measurement 1 week after. And what we have seen is that right after ischemia reperfusion, lactate was highly increased by about 50%, bicarbonate was reduced. And then over time, this kind of increased lactate to bicarbonate ratio was reduced and went back to baseline only after 1 week. And that means that the metabolic alterations, they persist for longer than the functional abnormalities we have seen in these animal models. And that's very interesting indeed.
So yeah, that's the basic pathophysiology. So it's unraveled by this technology. So, but we have other technologies available like PET scanning and other techniques. So how does this technique, which is also looking at metabolism like PET scanning, how does that compare to PET scanning? What is the advantage, disadvantages as compared to these other technologies?
So let's start with the advantages. So the key advantage is that we can look at multiple metabolic substances at the same time. So meaning that if pyruvate is injected, we can simultaneously follow the buildup of lactate, bicarbonate, carbon dioxide in certain instances, and alanine. And that's quite different from using PET tracers, where we only see the PET tracer itself emitting at 511 keV. So we can't really tell apart the different substrates or products, metabolic products occurring from this tracer. And that's a key advantage of this technology. Secondly, it is considered to be non-invasive because there's no radiation involved in this process. And if we compare to PET, of course, there's also a limitation, and the limitation amounts to the concentration to be used of the tracer or the pyruvate substrate we have to inject there, while PET can work with picomolar, nanomolar, perhaps even concentrations. Here we have to use millimolar concentrations, so that's something to be kept in mind.
There may also be some technical issues that have to be resolved also with this technology. So I was thinking about the image processing Is that a reliable tool? The signal strength of the individual components? Is lactate the best signal, or the ratio? And what is the actual spatial resolution of the technology? So what are also here the issues?
Yes. So in terms of sensitivity, as I mentioned, we have to use rather high concentrations, so millimolar concentrations of the substrate to be injected. And then, of course, the products, they have even lower concentration, meaning that there will be a lower signal generated from these. And so great care has to be exercised to image these kind of compounds using MRI. And that in turn also results in a rather low spatial resolution, meaning that we talk here about 2 millimeter, 3 millimeter voxel sizes, which is sort of already borderline for these small animal models. But of course, the hope is that we can translate this technology into humans eventually. And then the resolution will probably be adequate. The key advantage still is that we have very high temporal resolution. We can follow the fate of these substrates at a 1 second time interval over half a minute, and that gives very interesting kinetic information about how these products are being converted. One issue, of course, that has to be mentioned is that while the compound that is being hyperpolarized undergoes decay, so once it leaves the hyperpolarizer, the compound decays, and the entire process has to be very, very much streamlined to have enough signal still upon injection. And when we compare or even just look forward into how this is being translated into humans, so that's one of the challenges. So while small animal models, so they have like rats, they have a high heart rate. Once we go into humans, the heart rate will be much lower. Hence, it will take longer for the substrate to arrive at the site of metabolic activity, in this case, the heart.
Okay, thank you. So maybe a final question. So you are also discussing some future applications. So people may be interested, what is the current status for human applications of this technology and how you see the future? And I know that there is also already some experimentation also in humans. Can you address this as a final point of our discussion?
Yes, the translation to humans is currently ongoing. There's already data from humans at a site in San Francisco, so where they installed a sterile hyperpolarizer that is being operated. And so they report feasibility, and they report very interesting results on prostate cancer using a similar probe, Pyruvate. Here in Zurich, we are currently in the process of applying for ethics approval of injecting Pyruvate for cardiac studies into humans. We expect this approval to arrive later this year, so hopefully in a year from now we can report on first experiments on humans using this technology. Again, it is to be seen how much signal there will be, given the fact that the human heart rate is much lower as compared to what we have in animals, small animals. But there's quite some hope that still sufficient signal can be detected so as to look at ischemia, transient ischemia, as we have done it in the small animal model described in the paper.
That sounds exciting. So I look forward to your future submissions to radiology in this respect. And I thank you for your feedback on this very interesting paper. Thank you.
Thank you very much, Dr. Roos.